Even if I feel like Madonna with this mic, my name is Daniela Rojas Castro, and I am coming here today to speak on behalf of AID, a French NGO, even if I am currently the Community-Based Research Department Director of Coalition Plus, which is a coalition of 15 community-based organizations and present in almost 40 countries. So, this is the long and winding road that we have taken to have PrEP in France. The work started quite before 2012, even if this is what it says. I would say that we started speaking about it seriously in 2009. And then there were a lot of other steps that I'm not going to describe because you have seen this slide a lot of times. But all these things help to create a favorable context to have PrEP. We wouldn't have had PrEP and a fully reimbursement of PrEP if it wasn't thanks to science. I mean, IPREX, PROUD, and RSCPRGET were fundamental, but also were community-based services like Flash PrEP in France and Flash PrEP in Europe. We wouldn't have had PrEP without the experience of the United States and other countries. We wouldn't have had PrEP without the mobilization and consensus launched by community and treatment activists like TRT5. Then we wouldn't have had PrEP without the favorable recommendations from experts, WHO, CDC, Le Rapport Morla, etc. In other words, we wouldn't have had PrEP without lots of areas of different expertise and with lots of mobilization. Where are we now? Here you can see the figures of the Safety Medical Agency. And as you can see, the numbers grow, but they grow slowly. Richard will say too slowly. And as you can see, the arrival of generics hasn't had an impact on numbers. Or maybe you could say hasn't had an impact on the evolution of knowledge about the availability of PrEP, hasn't changed the people who are coming to ask for PrEP, it hasn't changed the medical practices. So there is a very, very slow evolution regarding access to PrEP. I must say that in May 2017 we started the ANRS Prevenir study, so there are 1,000 more people. So we can estimate that in France there are currently 7,000 people on PrEP. Since PrEP implementation in France was thinking on the basis of the Aidsfonds trial, there is an important place for peers, coaches at hospitals' PrEP consultations. You know that in France we only have access to PrEP at hospitals. So let me give you some key figures. 138 activists doing PrEP coaching in 2016 and 17. More than 3,000 PrEP users being accompanied by a peer coach. The number of interviews conducted by AID has doubled from 1,500 to 3,400 in 1 year. In 2016, we were present at 50 hospitals, and almost 30% of all the PrEP users in France have been coached by peers. Here you have some data regarding the PrEP users that are seen by AID. Median age is 37, and let me present the other data in another way. Only 0.5 are women, only 0.2 are heterosexuals, only 14% are born abroad, only 3% are injected drug users. As for chemsex, an item was included in our surveys, and we found that 29% of PrEP users reported chemsex. For this slide, let me stress the figure on the right. It concerns the last visit of all people using PrEP. As you can see, 40% prefer on-demand versus continuous schema, just like in the Prevenir study. What is much more interesting, and we see it much more, is that there are a lot of people who are using both regimes, and they alternate in function of their sexual lives. Categories are great for our work and for doing reports, but then the life of people is a little bit more complicated. PrEP authorization in France was a huge success and demanded a lot of work, but there is still a lot and lots of work to do. The number of PrEP users is insufficient to have an impact on the epidemic. We are reaching nationally and in the framework of Prevenir only white MSM between 30 and 40 years old, which is great, but it's not enough. We must increase the literacy of PrEP and facilitate access to PrEP for other communities. Regarding our will of leaving no one behind, is very disappointing what our data say. Several reasons can explain this situation. Some communities may be reluctant to PrEP because of misinformation, lack of information, but also because using PrEP has different meanings and effects depending on the social reality of these communities. For example, I had a colleague that was telling me the other day, in our country, sexual workers are not willing to use PrEP because to be a professional means using condoms, so they are not going to advocate for having access to PrEP. Surprise, surprise, there is also a lack of coordination among stakeholders. Then access to PrEP remains complex. You have to go to a hospital or to a CEDID, a sexual health center, and for migrants, for example, this might be a very important barrier. In the case of Prevenir study, for example, we observed that migrants are not able to engage in the follow-up that we are proposing. So sometimes they are using informal PrEP use, but we do not have any data regarding this. These are a few reasons, but there are certainly others, and there is no better way to identify, understand, and take action than following a community-based approach. Needs regarding health among this community must be identified, and actions must be taken by, for, and with communities. I don't know how many sex workers, women, migrants, drug users, and trans activists are here today, for example. So what are the next steps? First of all, we need to develop the political will of working among countries in Europe. And I would say not only about working together among health ministers, but also among NGOs who are doing a great work and moving forward. We need a frank communication regarding PrEP. In our country, for example, there are not really campaigns showing PrEP use in the subway, on the streets, with migrants, with drug users, even with gay men. It's been very hard. We need to improve communication on the on-demand regime. Health professionals function sometimes with the old models like pills. They in some cases have decided that continuous regime is better because people wouldn't be able to adapt their pill taking. And we think that this is something that is more reassuring for doctors, that's something that is adapted to the needs of the sexual life of people who are asking for PrEP. Besides, it's cheaper. We need more proactive and motivated stakeholders. And then PrEP has to be conceived not as a unique tool. I have this feeling we are always talking about PrEP consultation. We don't have to lose the idea that we are speaking about test and treat, TASP, mental health, sexuality issues, a lot of things. And since I am a researcher, let me say that I believe that we still need research to have more data and better understand what are the barriers for understand how vulnerable populations can access to PrEP. Thanks a lot.